Very interestingly, the subset analysis in German studies showed that maybe some patients, particularly our younger patients or males, underdose with rituximab. So several studies were actually designed to answer this question, except
that was explained because of faster clearance of rituximab.
Faster clearance of rituximab. I think the ones which were randomized is that was done by Hovon group, which randomized patients to standard dose R-CHOP versus increased dose rituximab R-CHOP, and then there was a second randomization to maintenance. And both of those strategies have no difference in the outcome. So increasing the dose of rituximab with CHOP did not improve the outcome, and additional rituximab maintenance to saturate all the possible receptors did not really affect the outcome of those patients, which again supports the initial findings that rituximab maintenance in this situation is probably not very helpful.
So to sort of conclude this frontline therapy, I have one more thing before we go into the wrapping of that session, or that part. I wanted to talk about CNS prophylaxis and how we manage CNS disease in patients rarely present with large cell lymphoma with CNS relapse, with CNS involvement at presentation, right? But what's the CNS prophylaxis and when do you do that? Dr. Mehta.
Yeah, so for CNS prophylaxis, so there's a CNS IPI score to help us identify patients at high risk of CNS progression or relapse. That is calculated by the IPI plus adrenal or renal involvement. And then we know that patients with double hit lymphoma have a higher risk of CNS, and double expressor lymphoma, at least retrospectively, have a much higher risk of CNS relapse or progression. As far as CNS prophylaxis, there's no good prospective data to suggest what the best way to do that is. But I would say that people usually use either high-dose methotrexate or IT methotrexate, mostly in the form of 3 cycles of IV methotrexate with the frontline therapy, or 4 intrathecal methotrexates.
No, I would agree with this. I think that it's established that in the rituximab era, the low risk CNS, secondary CNS, we see much less. But the patient who have high risk still we see, and these patients are not really prophylaxed well with IT, and I would recommend IV methotrexate. So to each one of you, very quickly, I want to tell me when you don't do, or you do more than R-CHOP in a patient with large cell lymphoma. Nathan.
So I think pretty much I still do dose-adjusted R-EPOCH and primary mediastinal large cell lymphomas in patients that have HIV, associated diffuse large B-cell lymphoma, and double hits.
The same, basically. HIV-associated large cell lymphoma, primary mediastinal B-cell lymphoma, and double hit lymphoma, those are just the EPOCH, but the rest of the patients are CHOP.
So how do you play with the CNS prophylaxis in double hit lymphoma?
It's a little bit challenging because we prefer, depend of the patient. If it's a patient who is young and can tolerate high-dose methotrexate, we pursue high-dose methotrexate. I mean, there is strategies doing at day 15, and actually there's published data, day 15 high-dose methotrexate. It may affect actually the intensification of the EPOCH. What I've been doing, I mean, this is kind of off trial, is to complete the EPOCH and then do the 3 cycles of high-dose methotrexate. And it's every 2 weeks, and you can finish in 3 weeks, in 4 weeks.
Peter, when do you want to R-CHOP?
So same settings, I agree. HIV, primary mediastinal, double hit. I will say
What are you doing double hit?
In double hit, we're doing our EPOCH, although, as I mentioned, there is a randomized phase 2 trial adding venetoclax that I hope will be positive. We can certainly do better, I think. Additionally, I will say that the CALGB 50803 trial did show a small trend towards improved outcomes in younger patients with very high IPI scores. So if I have a patient who I think has a very aggressive lymphoma biology through some sort of magic gestalt that I think all of us have intuitively, I have occasionally treated some of those patients with our EPOCH. Additionally, I agree with everything that's been said about adding high-dose methotrexate to patients that I believe have a high risk of CNS relapse. Not included in the CNS IPI are the testicular DLBCLs. Those patients were not in the clinical trials, but I think clearly they warrant high-dose methotrexate. Occasionally as well, all of those are examples of more intensive therapy. I think now that there's evidence to de-intensify therapy, so patients with stage 1, 2 DLBCL who have a very low IPI score, we're in the FLYER trial, the German FLYER trial that was presented last year at ASH. Those patients did equally well when treated with 4 cycles of R-CHOP plus 2 additional doses of rituximab, and presented here at ASH this year by Dan Persky. It is a SWOG trial that essentially is a single-arm phase 2 trial, but confirms again that patients with low-risk DLBCL who got a good response after 3 cycles can get 1 more cycle of R-CHOP and probably do not need additional therapy beyond that. So I think that's good news for our young patients whom we may have been over-treating in the past.
True. Great.
So this will be similar to our practice. I think thinking about this, we have to remember that the modern data show us that double-hit lymphoma are not necessarily as bad as we initially thought. So if initially we were looking at the curves, it almost looked like everybody was dying and dying very quickly. It was almost like a death sentence. This has changed quite a bit. If you do it actually prospectively in everybody, even with R-CHOP, the PFS is around 40%, and this has been shown now in from number of studies. Now, having said so, it's still worse than, definitely worse than with R-CHOP in the outcomes seen with R-CHOP in non-double-hit lymphoma. So in our practice, we use Codoxem IVAC for younger patients less than 60, and then we use either dose-adjusted EPOCH or R-CHOP in patients over 60, depending on the performance status and ability to tolerate chemotherapy. And participation in clinical trials clearly preferred in this setting.
Absolutely. Yep.
I mean, I would agree with everything that's been said already. The few things that I would add are in an elderly patient would consider our mini CHOP as opposed to R-CHOP if they're very old or have a lot of comorbidities, or in somebody who had cardiac dysfunction, substituting the etoposide. And then I agree with Greg, for the most part in double-hit patients, I would use dose-adjusted R-EPOCH, but if I have a really young person who's behaving almost Burkitt's-like, I'll use the R-Codox regimen.
Yeah, we used Codoxem IVAC as well, McGrath, in patient with double hit and patient with a double expressor or high risk, very high risk presentation. As Peter said, the patient that has really bad presentation, we actually use EPOCH in older patient. Otherwise, we use modified hyperCVAD if they have a higher CNS risk, where we increase the dose of methotrexate to make sure that we have a CNS prophylaxis. I wanted to cover when you do less on R-CHOP, but I didn't have to because you covered that.